صحبي أجمعين. Ladies and gentlemen, thank you very much for being here. This is the start of our second edition of the National Heart Forum. I hope that you found the registration an easy process and you didn't have any complications and any problems with that. And I hope that you like our program this year. To start with, the first session is the National Heart Center's role in promoting new technology, science, and collaboration of all health providers. We have a number of presentations. We'll start with Dr. Hani Sabbour, who's going to talk about population health approaches in cardiovascular management. Then we will go to Abdulaziz Al-Hamoud, who is going to talk to us about telecardiac services at Saha Virtual Hospital. I will be talking to you about real-world data and real-world evidence. And Dr. Huda Alferdous will be talking to you about research and innovation in cardiac sciences. And Dr. Mohammad Alhamali will talk about the role of regulatory sandboxing in leveraging digital health innovation. We'll start with Dr. Hani Sabbour. Dr. Hani Sabbour is an assistant professor of cardiology at Brown University Medical School, Rhode Island, USA. He is also leading the cardiology population health management at Abu Dhabi Cleveland Clinic. He is a very well-known speaker. I've heard him speak many times about population health and cardiovascular management. I'm sure that you will be impressed by his presentation. So I'll leave the floor to Dr. Hani. Thank you very much, Dr. Hani, and sorry for the wait. Thank you very much. The floor is yours.
Thank you very much, Dr. Adil. It's really a great pleasure to be invited to your wonderful conference. It's really a privilege to be part of your amazing meeting. And also, you're too kind in the introduction. I'm just a basic cardiologist with an interest in prevention. So, Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. So I will try to highlight a very important project that started by the Abu Dhabi Department of Health. It's a public health cardiovascular disease management. And I'd like to share with you some of the impacts on population health using LDL as the primary target. So in the UAE, we have a tremendous burden of early cardiovascular disease. The proportion of patients under the age of 60 is very high, and premature mortality, mostly from cardiovascular disease, accounts for 19% of deaths. And you're familiar with the fact that the average age of MI in the UAE is about 49 years, 11 years younger than US and EU. And the other very dangerous thing, there's a 30% increase in the cardiovascular deaths year on year in the last 10 years. And we have discovered that dyslipidemia is actually the #1 risk factor for CVD in patients' mortality. The other very important point that was discovered by the Department of Health through a very important validation project was that when we looked at the 6 major risk equations, whether it's the ACC, WHO, Framingham, or the Euroscore, we found there was only a 55% concordance between all of these from a cohort of 2,000 patients with known coronary artery disease. This is a huge challenge for anybody making clinical decisions in primary prevention in the country. And one of the main drivers of this problem is that all the calculators are highly dependent on age being above 40. And due to the young patient with events in the UAE, these are very inaccurate tools. When we looked at dyslipidemia, and you're very familiar with this, this is from the DICES-2 ACS study, 76% of patients with known coronary artery disease and 88% of patients with ACS were not at the old LDL goal of 1.8. And if you take 1.4, that number would maybe approach 96%. Also, familial hyperlipidemia is very common. This is a study that we were very privileged to be part of with Dr. Khalid Habib and the team from Saudi Arabia. And the estimated FH prevalence in the region is 0.9%, 1 in 112 nationals. It's 4 times higher than the EU. And of course, none of these patients were at the LDL target for FH. Whether they were high risk or very high risk, 97% not at target. I also am privileged to work at one of the large diabetes centers in the country. There's 42,000 diabetic patients. 95% of these patients have hyperlipidemia with high or very high cardiovascular risk. Even though the 94% were on statins, how many patients were actually at target? Actually, in these patients, 71%, i.e. 23,000 patients, had a mean LDL of 3.1, nowhere near any of the guideline recommended targets. This therefore results in a 40% death rate from cardiovascular disease. Mortality due to CV disease is 147 per 100,000 population, a huge impact of diabetes, overweight, cigarette smoking, and hyperlipidemia. And we estimated that 14,000 lives could be saved in the next 2 years, the next 10 years, I'm sorry, by implementing the WHO best buys, especially lipid-lowering targets. So the status now is uncontrolled hyperlipidemia in the UAE, urgent public health issue, very large magnitude, lethal implications. So the consensus was we need to have a population health implementation, not one doctor at a time. So the data for this is basically from all of the randomized clinical studies. If you looked at statin therapy, a 1 millimole reduction is a 20% risk of CV events. If you looked at statin, ezetimibe, PCSK9, more recent meta-analysis, again, 1 millimole, 39 milligrams, 20% reduction of CV events. In reality, what happens is the opposite. Failure to achieve the LDL target increases the risk by 20%, and that's something that the public health system has to address. This is very clear. Very high-risk patients need to achieve an LDL of less than 1.4 or 55, and high-risk patients need to let 1.8, and ACS patients with recurrent events need to achieve 1.0 from the guidelines. So the population health concept was a partnership with the Department of Health in Abu Dhabi, which is the main regulator and payer, and they thought of it in this way: the population health as a novel concept with high impact, high value on fatal, non-fatal events. Population level, I mean large numbers, LDL control will provide a predictable reduction in cardiovascular events. The main tool that we have is the Malafi National Electronic Medical Record, which links now all hospitals and clinics and labs in the UAE. It's a very powerful platform that allows us to identify individual patients' LDL and their level of risk for the whole population, regardless of provider or facility. This is not possible in the USA due to the fractured healthcare system. However, there's still fragmentation, there's still difference between insurance, there's still different implementation of the guidelines and decision-making, so therefore we needed to have a national lipid pathway for LDL control. And this is actually from the WHO model, the best buys, as I mentioned. If you pay less for prevention, you will have to pay a lot more for hospital treatment. If you pay upfront and invest more in prevention, you will have to pay much less in hospital treatment and have more survival and less cardiovascular events. So this is the program that was actually signed between the Department of Health and Novartis as the primary sponsor of the study, as well as the actual implementation. So this is the general idea. If you take, and this is derived from the Da Vinci study, but the same idea applies. The mean LDL in patients with ACS was about 2.4. By bringing that down to 1.4 with comprehensive combined lipid-lowering therapy, the work would be that we would decrease the cardiovascular risk in the population, shifting the entire curve down to 1.4. So that means we decrease the 10-year risk from 40% to 30%. Still high, but it's going to decrease that over 15% of the whole population with ASCVD using combination lipid-lowering therapy. However, doing that doctor to doctor, patient to patient, and depending on variability of patient's response is not really appropriate if you want to have this massive reduction of LDL. So this is a very ambitious program. When we looked into the electronic medical record, we found that there were 74,000 patients who are very high risk and not at LDL target. With implementation, we assume, and this is the model, that 6,000 lives would be saved over 10 years, about 3,800 nationals and 2,500 expats, and 92% improvement in patients commencing and maintaining lipid-lowering therapy, and an 8 times increase in the number of people achieving the cholesterol target. And in addition, approximately 12,000 non-fatal events would be averted over 10 years. So when we talk about intensive lipid lowering, long-term adherence is the key to this success. This is from the European Heart Prevention Study, almost 2 million patients, 130,000 CV events, and 94,000 mortalities. And what was clearly discovered, that non-adherence with cardiovascular disease medications, particularly statins, is extremely important. In the European study, 40% of patients were non-adherent. 9% of all European events are attributed to vascular non-compliance with medications. So non-adherence is now the most powerful risk factor for CV events and mortality, because the patients have diagnosis, but they're not getting the treatment. So why did the DOH start with the population health program using inclisiran? For two reasons: durable and long-term sustained LDL control using basically 2 injections a year, basically a vaccine-like approach for thousands of patients. So this is the scientific inspiration. When Professor Braunwald gave this speech last year at the ACC, I think it was very helpful. If you take a 30-year-old patient with an LDL of 100, which is basically where most patients have their MI, you give them an inclisiran dose once a year with the flu vaccination, 40% LDL reduction over 40 years would actually intensively prevent plaque formation or progression from the beginning. Now, this is off-label, but that's sort of the idea, a vaccine against LDL. From the practical standpoint, this is what we know from the evidence from the Orion 9, 10, 11 studies. 50% reduction of LDL over 1.5 years with 4 injections. From a system standpoint, this is very easy to accomplish. And in addition, 87% of patients in the Orion studies achieved an LDL of less than 70, which is the target for high-risk patients. The Orion open label extension, the 4-year data, showed you exactly the same thing. With 9 injections over 4 years, again, very simple for the system to implement, 50% sustained reductions of LDL, regardless of where you started. Now, how does this impact outcome? By solving both intensity and adherence, an LDL reduction in the Orion studies was 1.3 to 1.4 at day 90, and also at the 1.5-year point with 4 injections, but we also saw a 25% reduction in major adverse cardiac events over that 3 years. So with that simple intervention, 4 injections, 1.5 years, MACE reduction over a shorter period of time, and intensive lipid lowering. Now, when we take a leaf from the 4-year study, where we had a very significant reduction of the LDL, we were able to see a 25%, 23% reduction of MACE events using PCSK9 monoclonal antibody over 5 years. But this requires 100% adherence, and 5 years, 26 injections per year, that's 130 injections with 100% adherence. I would expect if you have 10 injections of siRNA with 100% compliance and no missed doses, maybe the same, but maybe a better effect. Now, the benefit of inclisiran is this clinical observation. No variability in clinical response. This is a typical patient. With dose 1, you go all the way down to less than 0.5, and you stay there consistently. This is almost 1.5 years of data, as we saw from Orion. The problem when you use oral medications with the patient has to take is statin ezetimibe. This is what you get. Over the last 10 years, this man has a lot of LDL variability, which means that even though you got them for 1 or 2 readings in the last 10 years to less than 1.0, the majority of the readings are not at target. 73 out of 76 regions are above target, and therefore the cumulative exposure is not at the level of protection of atherosclerosis. So this is how you eliminate variability or non-compliance. From uncontrolled LDL over many years in the orange bar, when we gave inclisiran for the last year, this patient is now very well controlled at 1.0. The other thing is because of the long-term effect of the PCSK9 inhibition. It prevents production of PCSK9. This is one of our non-compliant patients. After a single dose, the patient had an 80% reduction, missed the 90-day booster dose, but 7 months later is still less than 1 at 0.82. So this is telling us long-term sustained efficacy is very beneficial for a population health program. So this is how the project was designed. This is the population health. There are multiple working groups for this to be implemented, national lipid pathway to make standard protocols, LDL metrics, patient continuity of care, data generation, and of course, a funding mechanism to pay for this project. And the project started like this. We focused initially on secondary prevention and diabetics with known ASCVD. Later on, we're going to go to primary and secondary prevention and then roll it out to the other regions of the UAE. And we have started the pilot phase with the population health program, which I will show you here. So we've had the opportunity to publish our pilot phase inclisiran population health project. It was presented and published in the British Society for Endocrinology last year in November. This is a snapshot of the data. So we started in 146 patients in the project with a pre-treatment LDL of 3.68, post-treatment LDL mean was 1.78, and there are some super responders who dropped to even less than 1.0. Maximum reductions of 92%, mean reduction 57%, as we saw from Orion over the course of a year. And when you looked at the waterfall plot, which describes this in more graphical terms, this is the majority of patients. 62% had 50% or more. 30% of those dropped to even 90%. And we only had these patients in the red. This is a very strange group. These patients who were prescribed the medication but did not achieve it, not given it due to insurance delay. And we've gone back to the insurance companies and told them, this is a big mistake. You are actually allowing your patients to have higher cholesterol and therefore higher events. Please do not reject these life-saving therapies. So this is basically the model. The Department of Health in the UAE took a different approach from the NHS. So the NHS UK, as you know, has a very similar program. But because we have an expanded population of diabetes in the last 10 years, type 2 diabetes has increased by 17%, pre-diabetes has increased to 35%. The decision was made by the regulator, in addition to ASCVD and secondary prevention, to exclude very high risk and high risk primary prevention diabetics. Who are the very high risk diabetics? Diabetics with complications, target organ damage, renal, retinopathy, LVH. Also, diabetics with multiple risk factors, obesity, BMI, smoking, males, premenopausal, postmenopausal females, long-standing type 1 diabetics, and of course, all diabetics with ASCVD. In addition, high-risk diabetics with one risk factor or more than 10 years of diabetes. Also, all ASCVD patients are included. So patients with primary events, patients with revascularization, CABG, PCI, patients with arterial revascularization, and patients with stroke or TIA. In addition, anybody with documented ASCVD on imaging, CT scan, angiography, or carotid Doppler, or an abnormal ABI. Here, the targets in both groups are 1.4 or 55, plus a 50% reduction. And in the extreme high risk, 1.0 becomes the target. There are other groups, which I won't go into detail, but primarily familial hyperlipidemia with multiple risk factors and patients with CKD and severe CKD as well, as per the guidelines. Now, as I mentioned, we are asking physicians, if the scoring system is low, do not exclude patients from this program. It is probably underestimated due to age. If the scoring system is high, whatever, if you use ACC or European score, please include the patients, but don't just depend on the score in these patients. So overall, this is basically the summary of the benefit of this program. The CVD prevention will have an enormous benefit on survival and cost. And as we focus on very high risk and diabetes, using the 4 clinically proven interventions and primarily focusing on lipid, diabetes, and smoking, 32,000 deaths and almost 20 billion dirhams will be averted in the next 10 years, almost $5.6 billion US in direct and indirect economic costs. And with that, I thank you very much. I'm sorry if I went over time a little bit, and I'll give it back to the chair for any questions or discussions.
Thank you very much, Dr. Hani, and please stay with us. We will have a couple of questions from the audience, but let me start with just welcoming, first of all of you again, whoever came in late, and asking Dr. Abdulaziz Al-Rabi'a, who is joining us from the Saudi Health Council. He leads he's the director of health policies and health economics center at the Saudi Health Council. Now, the main messages that Dr. Hani was mentioning is that what we need to do with the LDL cholesterol and its relationship with atherosclerotic cardiovascular disease is mainly a policy. And this policy would depend on clear evidence, clear guidelines, and we did do that exercise. Dr. Jamila Rahimi was with us, and she led, in fact, the development of the national dyslipidemia guidelines, which we will talk about in details later on during the forum. What is the meaning of a policy brief, and how can we, as physicians, learn to work with the policymakers or with people of your expertise to write a policy, especially on this situation? Can we have the mic to Dr. Abdulaziz, please? A mic. And really, I would like to congratulate you, Dr. Hani, for the excellent program at Abu Dhabi. It's really fantastic. Go ahead, Dr. Abdulaziz.
Thank you very much, Dr. Adil. It's a pleasure to be among you today. And I really congratulate you and the team with this opening and this great conference. So I was really enlightened about seeing the impact of these interventions and how it has an impact economically and also on policy down the road. So maybe you had a couple of discussions about how do we look into policy briefs and how we can really disseminate this knowledge into our community as clinical practitioners. So if we look into a policy brief, basically it means that it's like a concise topic or concise review about a policy challenge, and that is addressed to be gathered in a scientific way that policymakers and stakeholders can understand and take an action legislation-wise and regulation-wise. So if we want to basically highlight this, how can we approach it from a policy brief? Basically, you need to identify where is the problem, and then how do you analyze it? What's the data or the scientific literature behind it? And then you need to analyze it. So what's the impact, cost, and feasibility of applying it? And mashallah, it was very well covered there. And then beyond that, how do we decide where to move forward? And finally, to measure it. So I think it's very important that we start some sort of like policy briefs and policy dialogues, especially among care providers. And one important things we can see from the topic we can take is how we can introduce some policy that is related to health financing. So basically to cover special medications, policy access to certain medications. All of this is important to also optimize the care, especially when we're moving toward the population health management. And the Kingdom is on that steps toward that with the universal health coverage. Thank you.
Thank you very much. Thank you, Dr. Abdulaziz. And I think we really need to work with you hand in hand on policy briefs in cardiovascular care, especially in the prevention side. I'll open the floor for a few questions before we we have to leave for the opening ceremony. So I'll open the floor for a few questions. تفضل Prof. Sorry. Mic for Professor Mary, please.
Well, thank you very much. Very well said by Dr. Hani during his talk, and it was great. However, first of all, I have a comment that compliance and adherence never 100%. And we know even from vaccination that you will miss one of the vaccination dose at any stage of 1 year or 2 years. So 100%, I don't think there is anything in medicine called 100%. Secondly, that the study previously from the PCSK9 inhibitors, that it showed that more than 90% adherence, but never been 100%. Even in the trial, you will have some of the patients is missing. So for this reason, if we have a PCSK9 with more than 90% adherence and more than 50% reduction of the LDL, with a very strong outcome from the 4-year trial, as you have referred, there is 2 questions. The first question, that the dose, if missing dose, do you need to reload by inclisiran or no? And if you are reloading, then Please calculate the cost. Secondly, is there I know I'm not aware about outcome trials for the inclisiran, but it is in the process of coming in 2027. Do you have any information earlier than that?
Thank you very much. It's a very, very brilliant observation. So, we recognize that even with vaccine approach, there's going to be some dropout. So what we've actually designed is an application. So the same application that was being used during COVID is now being repurposed for notification of the patient. So we're going to tell the patient, you're due for your vaccine. It will continue to keep flagging. It will give them a red. And in addition, we also have basically coordinators, which will, they're sort of like lipid educators that will call the patient. So we will continue the process of reminding the patient directly through the app and through telephone conversations. So there is a little bit of a big infrastructure. As I mentioned, there's a lot of things that are built into this pathway that are structurally important, because as you mentioned, that is a key. So we are obviously trying to avoid a missed dose. So the rule with the missed dose is the following. If you are more than 90 days late, i.e. 3 months late, then you have to re-dose. In the exception, of course, if the patient, like I showed you, has a controlled LDL. I don't know that that's going to be a standard. So with the repeat dose, we're always getting another LDL in order to ensure that the patient is actually at the target. So that is built into the process itself. But the whole idea is to avoid missed doses and delays. The outcome studies, as you mentioned, are still pending. We're looking for the Orion 4 study. The basic idea that the Department of Health has also taken up is that with a large number of patients, there's a commercial agreement. Just like what happened in the NHS, the commercial agreement allows the government to have a tremendously large reduction in the cost. Because of the large reduction in the cost, they're actually able to include thousands of non-UAE nationals, expats in the program. Basically, they're covering almost all the population in the UAE, in Abu Dhabi, with sort of a constricted cost equation. So there's many different factors. I couldn't really go into all the details. This has been ongoing for almost a year and a half. But as we all know, essentially LDL is not dependent. LDL lowering is not dependent on the therapy that is being utilized. All of the therapies are safe. All of them provide the 50% reduction. And we've just seen from the CLEAR outcome study, which is even not a PCSK9 and not even a statin, the additional reduction is requiring events. So the DOH has taken a sort of a more proactive approach in order to make this a broader population in addition to the commercial agreement.
Assalamu alaikum. Thank you so much, Dr. Hani. I think this was really a great talk and give us a great insight. Just to continue with our program, I would like to welcome Dr. Abdulaziz Al-Hamoud, who will give us a brief about the virtual cardiac care from the Sahha virtual hospital experience. Tfadal, Dr. Abdulaziz.
Thank you.
Thanks, Dr. Jamila. Sabah al-khair. It's so good to see a lot of faces that were part of our journey at the virtual hospital that started early in 2020. In the next few minutes, it's not going to be as a breakthrough as what the previous presentation was, but hopefully we'll take a lot of things to our locations, hospitals, and work groups and try to come up with something that helps our patient. So, so briefly, the virtual hospital is one of the largest of its kind in the world. It's leveraging all latest technologies, trying to provide care to our patients across different network of hospitals. Today, we have 166 hospitals participating in our network. That number keeps changing. Last time I presented 2 weeks ago was almost 150. And the reason why we were able to expand easily is to capitalize on what Saudi has done over the last few years with a good and very robust foundation that allows for communication between different hospitals. We provide today almost 46 different work streams and subspecialties. We were able to recruit more than 150 experts. A lot of them are in the room today. We're thankful for their participation with us, their support and their help in the design. The way we designed this virtual hospital allows us to provide care to almost 500,000 patients annually at complete setup. We have a clear focus on targets. We really want to enhance our experience. We want to enhance access to care. A lot of these elements in this slide were taken from the Vision 2030, where the transformation of healthcare is moving. We really want to bring knowledge easily to seekers across Saudi. No matter where you are, you have access to expertise almost instantly, and you see their action in motion. You see how they provide better outcome, how they really focus on clinical excellence. We're confident that we've achieved at least half of these. Telemedicine is not new. I like to share always this piece of not very clear write-ups from 1927, where people were envisioning how to use telemedicine using technologies that were available at that time. For example, Dr. Gale here was envisioning the use of telegraphy for telemedicine. But what we're after is not just telecommunication. We really want to bring the next version of healthcare. And we think we cracked the code of doing so. This is our approach. We were able to build an innovative organization focusing on personal traits, focusing on people who believe in change and the ability to do more with what we have. We came up with a standardized implementation pathways, capitalizing what has been published already across the different literature and different healthcare systems. And then we focused on people and collaboration. Incremental success is what keeps us going. The reason why such a project is successful in Saudi is because we have a clear strategy. We were lucky to be working around such a time where a vision is driving a lot of activities. The other value that we have, and it's not available in other countries sometimes, is the malleable regulation. The collaborative work with the Saudi Health Council and other decision maker helped us really understand the regulation and work around it to maybe optimize it, make it better, make it really suitable for the future interventions. In addition to any standard pieces that has to be part of your technology-enabled care, which is people, technology, and processes. Today, and I like the Arabic number in the middle, but the way we designed the virtual hospital has multiple streams, mainly allied services, radiology, pathology, capitalizing on committees and virtual heart and virtual teams. Really focus on ongoing critical care consultation, emergency care consultation, and acute care, in addition to the outpatient clinics and care at home. And the only reason why I highlighted these 5 work streams is our team, our cardiology experts at the virtual hospital, were able to provide care across all these pathways. You will see how we utilized these pathways and processes to provide the best care for cardiology. I don't want anybody to really stare at this slide. It's just going to make you confusing. But these are some of the specialties that we design. And the one thing that we were able to do is really bring everything that could make the workforce comfortable, really deal with their burnout, and then provide to the patient the perfect model. If you look at the first row, for example, you will see the heart failure group, the structural heart, the adult, and then the critical care and electrophysiology. But then if you go to the lower part, you will see our work with the global medicine, and cardiology was core when we provided some cardiac care across cross-border, disaster medicine, and this is our newest add to the virtual hospital that started during the recent disaster in the nearby countries. In the next few minutes, I will briefly have a deep dive into what we're doing at the cardiology and the virtual hospital. So one of the biggest and core service that we provide is the National Virtual Heart Committee, where a group of experts from different healthcare sectors in Saudi, whether it's MOH, university hospitals, or military or whatnot, every experts in Riyadh or in Saudi is part of is welcome to join this group. We've done it across 4 different streams. One focusing on structural heart disease, where we supervise some of the TAVI planning and procedure surgical planning, advanced heart failure, electrophysiology, pediatric, and adult advanced heart failure programs. One of the reasons why we were able to do a national approach and managing cases with some sort of a standardized strategy is the foundation, as I mentioned earlier, that really allowed us to move forward. For example, TAGI is an unheard of cardiac back system where you could really see any cardiac procedure done across multiple cardiac centers. If you have a time to go and just scroll around TAVI, you will see how such an approach allowed us to build upon it a heart committee, an RPM programs, and also facilitate for other interventions. We'll speak briefly about the RPM program, which is the remote heart patient monitoring program for advanced heart failures. There has been a lot of papers and suggestions, and the literature is full of how could you manage such complex cases at home. We brought the right pieces and capitalize on the approach of having multidisciplinary management program for heart failure. And then we've implemented such a program across 3 different cities in Saudi today. We're happy with how things are going. This is the start. We hope that any advanced heart failure patient will have their care continuous even after their discharge from the hospital. I like to call the other piece surgery 2.0, where Dr. Tash and the team is focusing on empowering surgeons and interventionists across Saudi with all what it takes to make them comfortable with what they're doing. And if they're performing a unique or a rare procedure, to make this available for other learners across Saudi. We've done a lot of quite a few live streaming surgeries. We've used augmented realities and other innovative technologies. This is just one of the images from the advanced heart committee meetings. The way the discussion is, and I'm sure a lot of the groups here were part of the discussion or submitted cases to the committee. How sophisticated the discussion is really what we're looking for. I believe any patient who would sit down and see the number of dialogues, the number of people who were part of their care plan will really feel that they're getting the most care that's not possible anywhere else. And the last, I'm almost done. I just want to ask you to stay tuned for the live streaming and surgery live streaming that's going to be presenting later on during this conference. And we're looking forward to seeing you soon. Thank you.
Thank you, Dr. Abdulaziz. I think this was an excellent overview. Any question for Dr. Abdulaziz before we go for our break and opening ceremony, and then we'll resume the lectures after that?
Thank you, Abdulaziz. What you present, it's actually a state of art of how does the cardiac care in Saudi Arabia is excelling. But my question to you, you mentioned that you guys taking care of the outpatient visit, and how this involved with the Ministry of Health, because you know that now the vision of 2030 to move more virtual care and try to reduce the number of patients that they actually come physically to the OBDs. We use this ANAT platform, to do this, but are you using the same platform, or do you have more solutions? And what are the future direction of collaboration between the National Heart Institute with the OBD for the Ministry of Health?
Thank you, Mohammed. This is a great question. So yeah, we're highlighting in all these national platforms, for example, Ihalati and Sahati or Anat. My recommendation is to always embed this within the process. So today, when we looked at the last reports, it was almost 21% of the virtual case care is being done at outpatient. I believe personally that when you have virtual medicine in the core of your practice, if your patient will definitely want at least one of every 5 outpatient transaction will be virtually, then capitalizing on other resources, ensure that there is continuity of care when network is complex or there's other challenges to the tools. But yeah, definitely we're using it, and we think, as mentioned in the previous presentation, having a national tool would really make it easy when it comes to penetrating the patient population, the ease of use, and the ease of access. Thank you.
Thank you, Dr. Abdulaziz. Any other question?
Thank you, Dr. Abdulaziz. 2 questions. The first one is, how do you envision tomorrow the role of the virtual hospital within referrals from primary care? So how it can easy access. Sometimes you need just a simple consultation for the patient, and that's what I do in the practice. It takes time sometimes. So to empower access, and secondly, how we can make the case when it comes to population health management. So I think one of the important plugs future-wise is how do you embed the virtual care within population health management? Thank you.
Thank you, Dr. Abdulaziz. Yeah, so one of the reasons why we didn't include primary care referrals at the beginning was trying to be mindful of the structure of MOH. If you ask me personally, I think it's the right thing. It's the right thing to really allow family physicians, consultants in family medicine that are leading state-of-art primary care centers today, where majority of the healthcare is delivered there. You should allow them to have access to that. It's in the pipeline. We're working on it right now. At the beginning, we didn't include it, just we wanted to move with the standard flow of MOH. The other question around the population health, we think that population health is strongly linked with technology, and having a technical hub will be the best way to implement population health. So 100%.
Thank you for Abdulaziz. I worked with Abdulaziz when we did the implementation for the FAB, which now is NHI with the R2. So I have actually 2 comments. Comment number 1 about how to connect the primary healthcare with virtual care, because we face, as R2, as Riyadh second cluster, we face a lot of patients and influx from the primary healthcare, because now people, they become more aware of primary healthcare. And we found that the 5 major specialties which we get referred from: ENT, ophthalmology, general surgery, and dermatology. And most of these cases actually can be dealt with in the virtual platform. We apply this, and we actually found a very excellent patient satisfaction and decrease the load in screen. Actually, we close all the screen clinic after we implement the virtual care. But my question to Abdulaziz, you guys mentioned about the policies and procedure and how you're going to connect this with because what presented here, it's clearly cardiology driven, because this is all LDL, but how are you going to take this level to the level of the primary healthcare? Because the whole idea of health transformation is to push the patient to the primary healthcare and try to decrease the number of patients visiting hospitals, and also to get more healthier population. How you see the family physicians and general practitioners being involved in these policies, and how we're going to make these policies easy for them? Thank you.
So maybe if I can take a guess instead of Abdulaziz, but I think one of the major areas that you can drive efficiency there is, for example, heart failure. And we know that basically you can activate patient telemonitoring and drive proper engagement between physician and patient, especially in primary care. You don't need to have a secondary care or a specialized care. I think what we are going through is an era for digital transformation, and going through like unified medical record, telemonitoring. These will take action in place, and also from the side of the patient, because they need to believe on that, because it has 2 parts. And I think down the road, we'll start to see some policies that comes to patient access where you can empower patient. And I think also we have seen in COVID time where Medicare, for example, start to have some policy on financials that having virtual care to the same, let's say the same coverage financially with the traditional or the physical care. So I think it's a journey, and it will need some sort of guidelines, eligibility criteria, education, both sides, from physician and practitioners, and also from the patient side. I hope that answers your question. Thank you.
Yeah, may I ask a question, Dr. Abdulaziz? So far you have achieved, I think it's a great, great idea, great project. Now, in terms of acute cardiac care, it's part of it. For example, like one of the common symptom, like acute chest pain, a patient having chest pain. Now, what is the access? How is the access? How's the mechanism? This is one question. Number two is that, do you have so far any data that how much did you achieve so far, like in terms of patient quick care, rapidly accessing the patient to the cardiac care, where we are right now? Do you have any idea?
Perfect. So we proved the model with telestroke. So now we have dedicated 24/7 stroke subspecialists available for emergency medicine when someone presents with an acute stroke, for example. We haven't done this with cardiology yet, giving the breadth, giving also the level of comfort that a lot of internists and emergency physicians were able to do the ACLS, basic way of saving lives. Okay, and then we're working closely with the Red Crescent, trying to support them. Our last meeting was just a few days ago. We want to bring our cardiac expertise to patients when the moment they have the chest pain. Our vision, like where I want to see this 20 years or maybe 10 years from now, is really having the abortive therapy, thrombolytic therapy for any cardiac event that happens in Saudi. But until now, we haven't tapped into the emergency room for cardiology, just giving the breadth and the complexity, and that we're not able to have all data available at bedside when the decision has to be made in split seconds.
Thank you, Dr. Abdulaziz, again. And I think this is a great interactive thoughts sharing. Maybe the last question before we go for our opening.
Assalamu alaikum. Maybe a comment rather than a question, but I think one of the issues that was highlighted by Dr. Hani was the availability in Abu Dhabi of a single platform to integrate patient data, Malafi. And one of the challenges we have in Saudi Arabia is the fragmentation of the medical records. And I think everyone is concerned about the enormous cost of having a single medical record at national level that would integrate all levels of care, prevention, primary care, secondary care, all hospitals, all sectors. This is something I think is overdue, and I think it would make a population approach to health management much easier, because you would capture data in real time and you would be able to integrate things very easily. One of the limitations that we have seen in the TAGI project is the simple technological barriers sometimes when people cannot just transfer images, or when you cannot see images, where you have limitation in taking decisions. And I think this is much, much greater at patient level, at patient data level. And I think it's really time that we invest in an infrastructure, in a single platform at a national level, just as we have in other sectors where the data is secure, easily accessed by everyone.
Absolutely, and I don't think anyone disagree. We all agree, and I think we can stay tuned and complete this excellent interactive sessions after the opening ceremony. So let's break for the opening ceremony and see you after. Thank you, everyone.
هذا خلاص الجهاز اللي على الجهاز خلاص. اي نعم.
تبغى
لا 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 ما وين هو؟ لا لا كفايه. لا لا لا.
طيب معلش كنت حتقرا باسم الورقه.
اي
خلاص عشان
او
هذا الأفضل. أفكر كده عادي؟
اي سكر. اي عادي ما يستخدموه ما في مشكله. من على الجهاز. اسف.
خلاص كده تمام عادي.
اي خلاص ممتاز. ابو ركان ابو ركان وين موقع توقيع الاتفاقيات ابو ركان؟ بدر ابو ركان مكان توقيع الاتفاقيات وين بيكون؟ وبتجيبون طاوله يعني؟ غير هذا بوديوم المن. يعني كانه على بوديوم الاثنين. واقفين.
انا همشي معك
طيب خلاص. عيني عليك. ايام الخوالي. آخر آية في القرآن وش هي اللي بتحطونها؟ هاي شباب القرآن آخر آية في القرآن وش هي اللي حيذاع؟ هي آية كرسي بس؟ أوكي. هذه الحين ها؟ السلام ورحمة الله. بسم الله نبدأ وبه نستعين، والصلاة والسلام على أشرف الأنبياء والمرسلين. وطن عظيم تتوالى إنجازاته يوما بعد يوم، لنقف جميعا للسلام الملكي. سعادة الدكتور محمد بن خالد العبد العالي مساعد وزير الصحة، أصحاب المعالي والسعادة، أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم بكل خير. أهلا وسهلا بكم في حفل افتتاح ملتقى القلب الوطني الثاني بالمملكة، والذي ينظمه المجلس الصحي السعودي ممثلا بالمركز الوطني للقلب تحت رعاية صاحب المعالي وزير الصحة رئيس المجلس الصحي السعودي. ويأتي تنظيم الملتقى ضمن جهود المجلس الصحي السعودي في تطوير الخدمات الصحية وبناء القدرات البشرية الوطنية في المنظومة الصحية، حيث سيناقش الملتقى آخر المستجدات والتوجهات المستقبلية لتطوير الرعاية الصحية القلبية، والاطلاع على أفضل الممارسات المحلية والعالمية لتحسين صحة المجتمع وتعزيز جودة الرعاية الصحية القلبية، بالإضافة إلى استعراض العديد من المواضيع المتعلقة بأمراض القلب وتصلب الشرايين، يقوم بتقديمها نخبة من الخبراء والمتحدثين والمتخصصين من مختلف القطاعات الصحية والقطاعات ذوات العلاقة في المملكة. وخير ما نبدأ به حفلنا هذا آيات عطرات من كتاب الله الكريم.
بسم الله الرحمن الرحيم. الله لا إله إلا هو الحي القيوم، لا تأخذه سنة ولا نوم، له ما في السماوات وما في الأرض، من ذا الذي يشفع عنده إلا بإذنه، يعلم ما بين أيديهم وما خلفهم، ولا يحيطون بشيء من علمه إلا بما شاء، وسع كرسيه السماوات والأرض، ولا يؤوده حفظهما وهو العلي العظيم.
صدق الله العظيم. أيها الحفل الكريم، الآن نستمع وإياكم إلى كلمة رئيس ملتقى القلب الوطني الثاني بالمملكة سعادة الدكتور عادل بن عبد القادر طاش، المدير العام للمركز الوطني للقلب، لتسليط الضوء على الملتقى، فليتفضل وله الامتنان.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سعادة مساعد وزير الصحة الدكتور محمد العبد العالي، سعادة مساعد الأمين العام للمجلس الصحي السعودي الدكتور معتز بالله الرويثي. حياكم الله جميعا أصحاب السعادة والزملاء والزميلات الكرام، قادة القطاع الصحي في ملتقى القلب الثاني. أعتقد كلنا نعلم أن الأمراض القلب والشرايين هي السبب أو المسبب الأول للوفاة عالميا. على المستوى المحلي تقريبا 42% من نسبة الوفيات حسب آخر الإحصائيات بسبب أمراض القلب والشرايين. النسبة العظمى من ذلك بسبب أمراض القلب، أمراض شرايين القلب بشكل أكبر تركيز. في المملكة العربية السعودية عندنا تقريبا 300 من كل 100,000 نسمة يتوفون بسبب أمراض القلب والشرايين، بزيادة 100 عن المجتمع الغربي أو المجتمع الغربي ذات الدخل العالي. تقريبا في المجتمع الغربي 200 في كل 100,000. ما زال عندنا حقيقة عوامل الخطورة مرتفعة، من ارتفاع الكوليسترول إلى نسبة أمراض السكري في الدم، ونسبة الارتفاع في ضغط الدم، ونسب الأوبسيتي أو زيادة في الوزن. الحقيقة في المركز الوطني للقلب اللي هو يعتبر جزء وهو من المراكز التابعة للمجلس الصحي السعودي، يعتبر انه يعني الهدف من وجود المركز الوطني للقلب هو نفس او في نفس المسار الذي يكون في المجلس الصحي السعودي، ليكون مرجعية ملهمة، او نفس الرؤية ليكون مرجعية ملهمة لنظام صحي سعودي عالمي المستوى. وأيضا كذلك الأهداف الاستراتيجية لرؤية المملكة 2030 في القطاع الصحي، وهي الوقاية، تسهيل الوصول إلى الخدمات والجودة. الحقيقة المركز الوطني للقلب يعمل على كل مسار من هذه المسارات بشكل كبير جدا. بالنسبة للوقاية، التواصل عن طريق القنوات الإعلامية وقنوات التواصل الاجتماعي، وأيضا الحملات المجتمعية للوقاية من أمراض القلب تعتبر يعني من أساسيات دور المركز الوطني للقلب. كذلك عمل الأدلة الإرشادية للوقاية هي أيضا من الأعمال التي يقوم بها المركز الوطني للقلب. بالنسبة للوصول إلى الخدمات نعمل بشكل مكثف ومشاركة فاعلة ومشاركة مهمة مع وزارة الصحة، متمثلة بمستشفى صحة الافتراضي، للوصول لأكبر عدد من المرضى عن طريق استخدامات التقنية الحديثة. بالنسبة للجودة نقوم أيضا بالعمل مع السباهية والمركز السعودي وأيضا أقسام الجودة في المستشفيات ومراكز القلب، لتفعيل الجودة أو زيادة في الجودة في المستشفيات ومراكز القلب، وكذلك كتابة الأدلة الإرشادية وكتابة المعايير التي تعنى بهذا الجانب. بالنسبة لكفاءة الإنفاق وكفاءة عمل مراكز القلب، فقد أعددنا دليل إرشادي متكامل لزيادة كفاءة مراكز القلب، وإن شاء الله بإذن الله حيكون في يعني عرض مفصل لهذا. حقيقة يعني سعيد بوجودكم جميعا، وأتقدم بالشكر الجزيل لراعي الحفل معالي وزير الصحة، وأتقدم بالشكر الجزيل حقيقة للأمين العام للمجلس الصحي السعودي على دعمهم المتواصل. وحياكم الله جميعا، وأرحب بكم مرة أخرى، وأترك المجال للكلمات الأخرى. شكرا.
شكرا لسعادة الدكتور عادل طهش. أصحاب المعالي والسعادة، الحفل الكريم، إن مسؤوليات المجلس الصحي السعودي في هذه المرحلة المهمة تتعاظم لتطوير وتنظيم الخدمات الصحية في المملكة لمواكبة التطور الذي تعيشه مملكتنا في كافة المجالات. خدمة للمواطنين والمقيمين في جميع مناطق المملكة، وبقيادة معالي الأستاذ فهد الجلاجل وزير الصحة رئيس المجلس الصحي السعودي. يواصل المجلس تحقيق الأهداف وفق رؤية المملكة 2030 وبرنامج التحول الوطني. الآن نستمع وإياكم إلى كلمة سعادة الأمين العام للمجلس الصحي السعودي الدكتور نهار بن مزكي العازمي، يلقيها نيابة عنه الدكتور معتز بالله بن محمد الرويثي مساعد الأمين العام، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سعادة دكتور محمد بن خالد العبد العال مساعد وزير الصحة، أصحاب السعادة، أصحاب المعالي، الحضور الكرام، السلام عليكم ورحمة الله وبركاته. يسعدنا صراحة مشاركتكم في الملتقى الثاني للقلب، وهو من المؤتمرات والملتقيات الهامة في القطاع الصحي. ملتقانا تحت رعاية معالي وزير الصحة رئيس المجلس الصحي السعودي الأستاذ فهد بن عبد الرحمن الجلاجل. أتى تنظيم هذا الملتقى بناء على الجهود التي يقوم بها المجلس الصحي السعودي في تطوير الخدمات الصحية، وأيضا بناء القدرات البشرية الوطنية في المنظومة الصحية. هذا الملتقى سيكون بإذن الله مميزا بتغطية جوانب متنوعة في مجال القلب والأوعية الدموية. سيتم الحديث على تحسين مسار الرعاية الصحية القلبية. أيضا سيكون هناك اطلاع على الرعاية الصحية القلبية المبنية على القيمة، والاطلاع على التدخلات الحديثة في مجالات الجراحات القلبية. من المهم أيضا خلال هذا الملتقى الحديث على تحديات كثيرة في هذا المجال، من أهمها التوريد والأدوية فيما يخص القلب والأوعية الدموية في ضمن رحلة تحول القطاع الصحي بالمملكة. حقيقة إن المجلس الصحي السعودي يولي الرعاية الوقائية والعلاجية والإسعافية في مجال القلب اهتمام بالغ، حيث يتمثل ويتركز هذا الاهتمام من خلال المركز الوطني للقلب، والذي يعد مرجعاً وطنياً للخدمات الصحية في هذا المجال. أيضاً يعتبر ركيزة هامة في تطوير الخدمات الصحية في مجال القلب والمقدمة لمرضى القلب في المملكة، والحرص أن تكون هذه المعايير وفق أعلى المعايير العالمية، والهدف هو الوصول إلى أفضل النتائج والمؤشرات التي تعزز من حياة الفرد فيما يخص مجال القلب والأوعية الدموية. منذ إنشاء المركز الوطني للقلب كان هناك العمل على كثير من المبادرات الوطنية النوعية، نذكر منها على سبيل المثال إعداد الأدلة الإرشادية لأمراض القلب والأوعية الدموية، وأيضا العمل على مجموعة من الأنشطة سواء كانت تعليمية أو تطويرية لمقدمي الخدمات. هناك أعمال حالية يقوم فيها المركز، ونفخر في هذه الأعمال في المرحلة الحالية والمستقبلية. يمكن الإشارة لنظام أو برنامج خاص وطني لكفاءة وجودة عمل المراكز القلب في المملكة، وأيضا العمل على مشروع وطني فيما يخص السلامة الإسعافية. وهذا المشروع من الأعمال المباركة التي يقوم المركز على العمل فيها، ويحد المستهدف فيها في المناطق التي يوجد فيها تجمعات بشرية. كثير من الأعمال المباركة التي يقوم فيها هذا المركز من مشاريع ومبادرات وطنية. ختاماً أود أن أنقل لكم تحيات سعادة الأمين العام للمجلس الصحي السعودي الدكتور نهار بن مزكي العازمي، وشكره الجزيل لمعالي وزير الصحة رئيس المجلس الصحي السعودي الأستاذ فهد بن عبد الرحمن الجلاجل لرعاية هذا الملتقى، والشكر لسعادة الدكتور محمد العبد العالي على تشريفنا الحضور وافتتاح هذا الملتقى نيابة عن معالي الوزير، والشكر موصول لكم حضورنا الكرام وللمشاركين من المتحدثين والمختصين في هذا المجال. السلام عليكم ورحمة الله وبركاته.
شكرا للدكتور معتز الرويثي. أصحاب المعالي الحضور الكريم، الآن نستمع وإياكم إلى كلمة صاحب المعالي وزير الصحة رئيس المجلس الصحي السعودي راعي الحفل، يلقيها نيابة عن سعادة مساعد وزير الصحة دكتور محمد بن خالد العبد العالي، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. الصلاة والسلام على سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. الحضور الكرام، السلام عليكم ورحمة الله وبركاته. فخور وسعيد أن أكون متواجد بينكم اليوم. فخري أكبر أن أكون نيابة عن معالي الوزير راعي هذا البرنامج وهذا الملتقى، وأنقل لكم تحياته وأنقل لكم دعمه المستمر ومتابعته الدائمة لكل البرامج التي تخدم صحة هذا الوطن. وبلا شك أن ما يتعلق بالخدمات الصحية المقدمة في مجال رعاية القلب وخدمات القلب ومراكزه وبرامجه ومبادراته تعتبر ذات أولوية لعدة جوانب ذكرها زملائي اليوم في مقدماتهم وكلماتهم الجميلة الثرية الهامة جدا. الملتقى الثاني، وكونه الثاني احنا دائما لما نشوف ملتقى اول يكون عندنا هاجس متى نشوف الثاني، لانه مجرد ما يبدا الثاني معناته الثالث والرابع والعاشر والعشرين والثلاثين ان شاء الله في الطريق، وباذن الله يستمر انعقاده سنويا. احنا فخورين جدا في المملكه العربيه السعوديه بالعلماء من زملائنا وزميلاتنا في مجال القلب، سواء كانوا الاطباء في مجالات رعايه البالغين أو الأطفال أو الجراحات أو التدخلات أو الرعاية المساندة لها الصحية، والخدمات الأخرى التي تقدم كخدمات طبية مساعدة متخصصة في مجالات القلب، إضافة إلى الخدمات المتقدمة اللي تقدم على مستوى مراكز متقدمة. وإحنا نعرف أنه اليوم مراكز المملكة العربية السعودية الحمد لله في مجالات القلب ليست متميزة فقط على وذات قيمة وأثر في المستوى الوطني، وإنما أبعد من ذلك فلها قيمتها على المستوى الإقليمي والمستوى الدولي والعالمي، وثراء المعلومات التي يقدمها خبراءنا وعلمائنا فريد جدا. اليوم في المعرض أثناء الزيارة، وأنا أنصح كل من لم يزور المعرض حتى الآن أنه يزوروه، بيشوفوا تقنيات متقدمة جدا، وبعضها لها اليوم وجود في محتوى المملكة العربية السعودية وتوطين داخل المملكة العربية السعودية وإنتاج داخل المملكة العربية السعودية وتوجه بدء تطبيقها داخل المملكة العربية السعودية. لماذا تم اختيار ذلك؟ تم اختيار ذلك لأن البيئة الموجودة في المملكة العربية السعودية الداعمة للابتكار، الداعمة للبحث، الداعمة للتقدم، الداعمة لتبني التقنيات الحديثة جدا والمتقدمة فريدة ومتميزة. إضافة إلى ذلك البنى التحتية والبنى المتقدمة في المملكة العربية السعودية فيما يتعلق بالأمور التقنية أيضا متقدمة. الخبراء الموجودين في المملكة العربية السعودية يعتبرون أيضا صمام مهم جدا وبوابة مهمة جدا لكي نتمكن ليس فقط من أن نبدع فيما هو موجود، وإنما نستكشف آفاق ما هو أمامنا ونجعله أقرب، ونجعله لدينا اليوم سابقين فيه لدول العالم. صحيح أنه أمراض القلب تعتبر عبء مرضي مهم جدا في المملكة العربية السعودية لعدة عوامل ولعدة مسببات، بعضها له علاقة بأمور قد تكون مرتبطة بجينات، بعضها قد يكون له علاقة بأمور لها مكتسبة بسبب سلوكيات معينة وعوامل غذائية ولا وعوامل حركة ولا غيرها من العوامل الأخرى أو السلوكيات التي قد تضيف مخاطر على القلب والشرايين والأوعية الدموية. إلا أنه هنالك شيء واثقين فيه أكثر من هذه الحقيقة. يمكن هذه حقيقة بأنها تحدي اليوم، والأرقام اللي ذكرها الزملاء والدراسات اللي بتعرض هذه حقائق ما نقدر ننكرها، بس في حقيقة أقوى منها ومؤمنين فيها بشكل أقوى، أن إحنا إذا رغبنا بشيء بإذن الله نفعله. فإذا وضعنا هذه المشكلة أمامنا وعزمنا على حلها على مختلف الأصعدة الوقائية والأولية والتدخلية الثانوية والمتقدمة والمتخصصة وأبعد من ذلك حتى الابتكارية، فنحن بإذن الله قادرين على ذلك، وسيكون بإذن الله بجهود الموجودين جميعا وبمثل هذه الملتقيات التي تجمع الجميع لكي نضع كل ما هو جديد وكل ما هو مهم وكل ما هو قيم وخبراتنا ونتشاركها مع بعض، سيكون هنالك بإذن الله نواتج. الحوكمة قوية الحمد لله، عندنا مركز وطني لهذا التخصص في مظلة المجلس الصحي السعودي، مدعوم بكافة القطاعات الأخرى من وزارة الصحة والوزارات والجهات والهيئات الأخرى، كلها متضافرة جهودها لتخرج لنا نتائج متميزة بإذن الله. ولدينا جمعيات علمية رائدة نفتخر فيها جدا في فضاء هذه المنظومة ومكوناتها الرائعة والمتميزة بإذن الله. نتمنى التوفيق للجميع، وشكرا للمنظمين، شكرا لكل القائمين على هذا البرنامج، ونتمنى التوفيق بإذن الله لهم في المراحل القادمة، وسنجد بإذن الله ثمارها في كل مركز وفي كل موقع وفي كل مستشفى. وإذا قلنا مستشفيات الأيام هذه لازم نقول المستشفيات والمراكز المعتادة وكذلك الافتراضية وكذلك المتقدمة إن شاء الله في تقنياتها. نتمنى التوفيق للجميع، وللي جايين وزايرين الرياض من خارج الرياض استمتعوا بأجواء الرياض، نتمنى لكم إقامة سعيدة فيها. وللمتواجدين في وسط هذا العلم استمتعوا وأمتعونا معكم في صحتنا. توفيق للجميع إن شاء الله. شكرا.
حضورنا الكريم، وشكرا لسعادة الدكتور محمد عبد العالي. يسعدنا بقاء سعادة الدكتور محمد عبد العالي على المنصة الرئيسية لتكريم اللجان العلمية والتنظيمية والداعمين على جهودهم القيمة والفعالة في الملتقى، وهم: أولا الدكتور فواز المطيري رئيس اللجنة العلمية، الدكتور خالد اسكندر عضو اللجنة العلمية، الدكتور يحيى الحبيشي عضو اللجنة العلمية، الدكتورة جميلة الرحيمي عضو اللجنة العلمية، الدكتورة ميرفت الأصنج عضو اللجنة العلمية، الدكتور محمد الحمالي عضو اللجنة العلمية، الدكتور عبد الإله هوساوي عضو اللجنة العلمية، الدكتورة هدى الفردوس عضو اللجنة العلمية، والدكتور عبد العزيز الحمود عضو اللجنة العلمية. اللجنة التنظيمية يستلمها نيابة عنهم رئيس اللجنة الأستاذ مساعد الحارثي. شركة نوفارتس السعودية المحدودة الراعي الماسي للملتقى، ويستلمها نيابة عنهم رئيس علاجات أمراض القلب والأوعية الدموية الدكتور خالد المصري، فليتفضل. كما تسعد اللجنة التنظيمية تكريم الجهات المشاركة في النقل الحي المباشر لعمليات القلب في الملتقى، وهم: أولا مستشفى صحة الافتراضي، وتستلمها نيابة عنهم سعادة الرئيس التنفيذي المهندسة منى السبيعي، فلتتفضل. ثانيا مركز الملك فيصل لأمراض وجراحة القلب بمدينة الملك عبد العزيز الطبية بجدة، بوزارة الحرس الوطني، وتستلمها نيابة عنهم سعادة مدير المركز الدكتورة جميلة الرحيمي، فلتتفضل. ثالثا مستشفى الملك فهد للقوات المسلحة بجدة، وتستلمها نيابة عنهم سعادة الدكتورة ميرفت الأصنج، فلتتفضل. رابعا مستشفى الملك فهد التخصصي بتبوك، ويستلمها نيابة عنهم سعادة مدير المستشفى الدكتور فؤاد المالكي، فليتفضل. حضورنا الكريم، وعلى هامش ملتقى القلب الوطني الثاني بالمملكة، يسعدنا دعوة سعادة مساعد وزير الصحة الدكتور محمد العبد العالي لرعاية توقيع مذكرات التفاهم بين المجلس الصحي السعودي ممثلا بالمركز الوطني للقلب وعدد من الجهات لتطوير خدمات الرعاية القلبية بالمملكة، وهم: أولا المجلس الصحي السعودي ممثلا بالمركز الوطني للقلب، ويمثله سعادة الدكتور عادل طاش وجامعة الفيصل، ويمثلها سعادة نائب الرئيس للشؤون الإدارية والمالية وعميد كلية الطب الأستاذ الدكتور خالد القطان. ثانيا المجلس الصحي السعودي ممثلا بالمركز الوطني للقلب، ويمثله سعادة مدير عام المركز الدكتور عادل طاش وشركة بوستن ساينتفك، ويمثلها سعادة المدير العام التنفيذي مهندس باسل القحطاني. رابعا المجلس الصحي السعودي المجلس الصحي السعودي ممثلا بالمركز الوطني للقلب، ويمثله سعادة مدير عام المركز الدكتور عادل طاش وشركة سيجما فارما، ويمثلها سعادة المدير العام التنفيذي مهندس محمد خليل. ويمثل شركة ساجرة فارما، يمثلها سعادة المدير العام التنفيذي المهندس محمد خليل. رابعا المجلس الصحي السعودي ممثلا بالمركز الوطني للقلب، ويمثله سعادة مدير عام المركز الدكتور عادل طاش وشركة إفادة طبية، ويمثلها سعادة المدير التنفيذي الدكتور رفيق كايسي. ويمثل الشركة سعادة الأستاذ وأخيرا يتقدم المجلس الصحي السعودي بتقديم درع تذكاري لصاحب المعالي وزير الصحة رئيس المجلس الصحي السعودي على رعايته ودعمه لأعمال الملتقى، يستلم نيابة عنه سعادة مساعد وزير الصحة الدكتور محمد العبد العالي. وفي الختام نتقدم بجزيل الشكر وعظيم الامتنان لكل من ساهم في إنجاح هذا الملتقى، والشكر موصول لكافة الحضور والمتحدثين ورؤساء الجلسات على تكبدهم هذا العناء، ولسعادة الدكتور محمد العبد العالي مساعد وزير الصحة على دعمه وتشريفه لافتتاح فعاليات الملتقى. شكرا لكم أنتم ضيوفنا الأعزاء، والسلام عليكم ورحمة الله وبركاته.
طيب, Bismillah ar-Rahman ar-Rahim. So again, here we come to finish our first session. And I would like to welcome Dr. Huda Alferdous. Dr. Huda will give us about research and innovation in cardiac sciences. So welcome, Dr. Huda.
Thank you for inviting me to be part of this great event, and it's wonderful to be part of the national efforts for pushing the frontiers of the cardiovascular sciences. So my talk is a little bit different. I'm not going to use slides. I want it to be from my heart to your heart, since we're talking about the Heart Forum, and also because it's particularly about delivering a message in 10 minutes, and you know, it's just about enough time to actually go over some stories and some examples that would really put the point across. So the title of the talk was Research and Innovation in Cardiovascular Sciences. And the idea is that we want to turn research into innovation. It's actually not the same thing. We want to move forward from the discoveries, the scientific discoveries, to turn them into innovations. And actually, the main message is to turn those innovations into commercial products and revenue sources, and let's say a source or a profit source. Okay, this is not a common thought or like thought pattern or a mindset, but I know many of us here are either researchers, so they're scientific, they have a scientific discipline, or clinical or medical practitioners seeing patients and working in medical settings. And so for us, we see a lot of problems, and we might even think of solutions that could be suitable for those problems. And you know, when you come from outside and you think about what could the problems be, what could the good solutions be, and you're not in the context of it, those solutions might not be the best fit for those problems, right? But actually, the guys in the medical sector and the scientific sector are the most suited people for solving it. And so this is why when we have all of that effort directed toward investigating the issue that we see every day and then finding the solution, it's really gutting that those solutions are not coming out to the real world at a scale. And this is where that step of turning them into a commercial initiative is what makes that impact. Whether we like the return part of it, whether we care about it or not, is not certainly the motivation of many people in the scientific and medical field. We like to see the impact of what we create, but to reach that impact, sometimes this step is necessary, simply to scale the size of that impact. And so I said I'm going to give you some examples of some research initiatives and how those ones turn from the concept of research into the concept of innovation. So research at essence is actually inventions. You're inventing something new But then when you innovate with it, when it becomes an innovation, this is when you are using it differently. So you're doing the application side of things. And so I'll use 3 examples, 2 of them in the diagnosis and sort of like, you know, the phase before the patient is known to have a medical condition, and then the other examples in the treatment phase, right? So these are the 2 main stages, the treatment and diagnosis and treatment. In the main healthcare setting, and also scientific discoveries are trying to either speed up the process of diagnosis so that we can get to treat the patients faster, or improve the treatment's efficiency and quality. Of course, prevention is another story, but I wanted to talk about those 2 in particular because they're quite immediate to the patient's life. And so with regards to innovations, or let's say research that get turned into innovations, with the diagnosis side of things, at KAUST, we've done a research project, so I give credit to the research center there, focusing on lateral flow assays. This is focusing on discovering genetic biomarkers that will give us the risk factor for a predisposition to a certain cardiac condition. And so the biomarkers have been researched in the bio setting, okay? And then at the same time, in the material sciences and physics and engineering, the other department has designed a device similar to the pregnancy test device, that is the lateral flow sheet, essentially, that you move the liquid across, and then it gives you a band when you have that marker present. And so the collaboration between the 2 research group resulted in essentially fixing those markers on the lateral flow assay, and then balancing all the buffers and everything so that you can essentially detect those genetic factors for cardiac conditions in the population. Now, the innovation part was the fact that those 2 research projects are new in their scientific discovery, but they innovated the use of it. And then yet another step, it actually did go into the commercialization office, the technology transfer office, to be partnered up with another manufacturing facility so that it becomes at-home point of care kit, so that families can do that screening, and then they can go and see a genetic counselor that will then go through the actual genetic testing, the more accurate results. But this becomes like more of a screening step, just so that they can see a genetic counselor for further investigation, right? So for them to get that to the hands of patients, they had to go through that commercialization step. If they didn't, it would have been a publication that is worthy, and it would have been something that a lot of other scientific and medical practitioners benefiting from in knowledge. But that knowledge economy, if it wasn't turned into an actual commercial economy, it would have not reached the hands of patients. And that's basically what I mean by that message that I want to deliver through showing you, like, you know, a few examples of, let's say, something that sounds irrelevant is like, why do I want to commercialize my science or my medical practice? Apart from being a private doctor, but actually it's about solving the problems and commercializing that solution. So another example as well in the cardiovascular field was for a protein biomarker. That research we've done, it wasn't done in the kingdom, it was done outside at Leeds University in the UK, and it was about sampling the vasculature multiple times throughout the treatment, so it's monitoring the treatment efficiency to just make sure that, like, you know, every time we're getting an accurate diagnosis of the status of the treatment. So it's like more of a monitoring of treatment plus diagnosis of the stage of the disease. And that was, again, like, you know, adopted for clinical trials so that it can go commercial. So we know that once we go clinical trials, we go commercial. But the point is that, you know, you have to think about it as a product when you're creating it out there. Then the final example with the treatment is to do with the cardiovascular drugs. So a drug that was meant to be treating a cardiovascular / diabetes condition, and it was repurposed to be used for brain tumors. And so here is again when I talk about innovation. The scientific discovery was and the research was about using that drug to understand the molecular mechanism. It's going to block a certain molecular pathway. We know this from research. But when it became innovation, it actually went to treat something different. It went to treat a different condition. And so it's about that repurposing. And then again, it went through the commercialization route. So the main message, I hope that it's clear, we need to think about our research in an innovative way and those innovations into practical ways through scaling it up. And just like, a comment to tie in with the theme of the talk so far, we're talking about policy and regulation, and it's very important to take this into account as well. And so, those things are in place because they're looking at it at a bird eye view of what matters to all institutions and the national scale. And so we always talk about like the integration from bottom up and top down. Like, the bottom just means that we are the ones closer to the ground as practitioners and researchers, but then the top is meaning like we're looking at it from the top, seeing what is important for public health. And so, integration between those two will avoid later on problems with taking those solutions forward into the real world and getting them stopped because we missed those regulations. And I think I can conclude with one final example of like, a situation where innovations are really immediately needed. It's not just like a luxury of like, looking at research patents, which I know many of you, if you are doing research, like, you're aiming for that. And again, if you are a clinical practitioner, you want to start using new products in there to help your patients. And so this example is to do with A&E services and the load, the financial burden on it that perhaps would either add more pressure on the practitioners that they cannot be they be called, or the nurses to be called to the A&E, or actually to a hospital, especially with the privatization scenario that we have, that they will be, let's say, burdened financially to direct resources there. So, we've done something similar to what we have downstairs, which I thank the Heart Center, the National Heart Center, for organizing the hackathon, the Cardiovascular Medicine hackathon, which we have downstairs. If you would like to join, it's about brainstorming ideas to solve certain problems in the field. And that was one example that happened in one of the past scenarios like that, people finding ideas to solve the A&E through being practitioners, understanding their patients. And so the example was actually from a neurologist, not a cardiologist, but he said he sees seizure patients, and those seizure patients are having the episode of seizure at the random time. They fall, they break a limb, they injure themselves, and they end up in A&E. And he was able to predict when, through asking them questions like, when did you eat your food? When did you sleep? How many hours? All of that. He can predict when they get the episode of seizure, like, around afternoon time or whatever. Like, he gives them some, essentially he collects some data and gives them some predictions. And for us, that was an AI, a convertible model, right? He can put his knowledge into an AI solution and using technology, i.e. innovation, to start scaling this up. So now patients can, and their families can take care of the seizure episodes early on. And then that reduces the burden than AA. So as I say, I had the 10 minutes to just like, put this message across. Hopefully I convinced you somehow with a few examples. And again, we'd love to have you joining us at the hackathon downstairs happening right now. And it will be tomorrow that the winners will be selected for cash prizes for their innovations. And you don't have to have any ideas. You don't have to know technology, or you don't have to be already multidisciplinary. There are many great people that you can work with to come up with solutions and support as well from mentors. So if you feel like just curious, then come just downstairs to the basement level to just be part of the hackathon and move forward with the effort for the heart health in the kingdom. Thank you.
Thank you, Dr. For those fantastic. I think to move with the time, it's my pleasure now to introduce Dr. Mohammad Alhamali, who will talk about the role of regulatory sandboxing in leveraging digital health innovation. Fadal, Dr. Mohammad.
السلام عليكم، صبحكم الله بالخير جميعا. أتمنى الجميع يكون بأتم صحة وعافية، أنتم وأسرتكم الكريمة. صراحة ما شاء الله الدكتورة هدى she mentioned the hackathon. That's an amazing initiative by the Heart Forum. ويمكن حتى في الويكند ما شاء الله the Saudi chat GPT, a lot of new innovation and a lot of technologies. ما شاء الله نشوف عقول ملهمة ورواد في مجال الصحة. They try to conquer challenges في قطاع الصحة. I'll be demonstrating the activity that the Ministry of Health launched. يمكن ما يخفى عليكم التحديات اللي تواجه قطاع الصحة. actually يعني نشوف burden of disease is increasing. وإحنا دائما يمكن الدكتور عادل تطرق في الجلسة الأولى إنه we try to link it with a strategic objective when it comes to innovation and leveraging new technologies, either by facilitating access in healthcare services, improve the quality and the efficiency, or promote prevention against health risks. طبعا حنا when we talk about innovation, we try to link it to the quadruple aim, either a better outcome, improve clinical experience, or reduce the cost, or improve the patient experience. So these are the 4 elements that we focus on. ونشوف التغير والتكنولوجيز that's leading to the 4th industrial revolution. نشوف اليوم إن شاء الله بتكون معانا اللايف سيرجري ستريمينج وين اللجنة الوطنية تستخدم الاوجمانتد رياليتي in guiding السيرجنز في البريفرالز والارياز across the kingdom. طبعا يمكن واحدة من أمثلة الانوفيشن مستشفى صحة الافتراضي، وكيف انه مؤخرا يعني ولله الحمد فاز بالجائزة الحكومة الرقمية في leveraging emerging technology، وكيف ان استطعنا بالفوز فيها. طبعا يمكن في البداية بتطرق الآن احنا كونا لجنة وطنية للابتكار والساند بوكس مكونة من 13 عضو من جهات حكومية وشبه حكومية to empower the sandbox. والconcept of the sandbox is actually to have a safe environment. يمكن حنا في الميديسن نسوي clinical trials ونتأكد من safeguarding the patient and the value that is added. فلما نجي الآن التكنولوجي تغير الوضع، فكيف إنه يكون عندنا إطار فعلا a safe environment where we test and design pilots and make sure that we have a proof of concept before launching it to the market. ودائما التحدي with any new innovation، لو بعطي أمثلة أول ما جاء كريم للمملكة يعني كثير من التحديات اللي تكون تواجه في موضوع الأنظمة والتشريعات المسموح فيها. طيب ما بالك في أشياء تخص قطاع الصحة؟ How can we balance that؟ كيف التقدم في الانوفيشن ممكن أن على طول أقدر I launch it to the market and make sure that it's not harming the patient. طبعا حنا الobjectives في الساندبوكس أول حاجة يكون testing environment, also to quickly adopt innovation. Also this will increase the economic growth، وأيضا نعطي recommendation لأني regulations. لما يكون في new technology we can recommend new regulations مع أعضاء اللجنة الوطنية بحيث أن نتأكد أن فعلا we can adopt this innovation securely and safely. فاليوم عندنا على موقع وزارة الصحة portal for the sandbox and this is the process. أي شركة أو أي رائد أعمال في مجال الصحة، أي باحث، أي innovator, he can go and submit his idea. What we are looking for is only the potential. فاليوم مثلا في الهاكاثون أنت عندك بعض الأفكار اللي قد تكون لها قيمة مضافة في قطاع الصحة. You will be linked with expertise سواء من technical background سواء من healthcare background. They will guide you إلى ما الفكرة تتبلور وتكون على أرض الواقع. فيتم اختبار هذه الفكرة تروح خلال مراحل إلى أن تمر للجنة الوطنية للابتكار. بعد اعتمادها يتم design a pilot تأخذ من 4 to 6 months where we accelerate these solutions and نتأكد من تخرجها. وزارة الصحة تعطي شهادة as a recognition، ولكن حنا الآن نعمل مع السعودي FDA to be licensed. Any innovation يمر في مرحلة الساندبوكس يكون خلاص licensed and it's ready to be launched into the market. طبعا هذه الامباكت اللي قاعدين نشوفها في الساندبوكس سواء من ناحية تمكين المبتكرين في المملكة، أيضا من ناحية الريسيرش والإنسايتس اللي قاعدين نشوفها، designing الباثوي والبروسيس based على الديزيز based، أيضا من ناحية البارتنرشيب، وأيضا من ناحية الفايندينج فرص الاستثمار من ناحية الساندبوكس أيضا ووزارة الصحة. كل الشكر لكم وشكرا جزيلا. الله يعطيكم العافية.
Dr. Mohammed, I think the floor is open for discussion. We still have 5 minutes. Any questions? تفضل.
Very nice and interesting. Just can you go through the process? How do you protect الملكية الفكرية للinnovators before it becomes mature? يعني when you have an idea, you really don't want to talk about it until it's ready to be implemented. Otherwise يعني بقلدك مليون واحد يعني.
سؤال جميل. هذه فعلا أحد التحديات اللي كيف إنه ممكن نمكن المبتكرين ورواد الصحة. كان أحد التحديات اللي شفناها إنه الخوف على الملكية الفكرية. فتعاوننا مع المعهد الوطني للأبحاث وأيضا مع إدارة الأبحاث في وزارة الصحة. The first moment you submit through the portal يكون فيه حقوق فكرية محفوظة لك. So we help you to secure an intellectual property على الفكرة المقدمة through the portal.
Any other comment? يعطيك العافية دكتور محمد. Thank you so much. I think that was really a great enlightenment. With that, we conclude our first session. And I would like to thank all our speakers. And here we will come to the second session. So I will give the mic to Dr. Fawaz Al-Mutari, who will lead the intervention cardiology, current and future.
Thank you very much, Dr. Jamila. It's a great start of our forum. So with this, I will just kindly invite our dear panelists, Dr. Mohammad Alhamali, Dr. Rasha Al-Bawardi, and Dr. Abdullah Alhamdan. Dr. Hamid, kindly. Dr. Rasha Aram. So in this session, we'll try to go over the interventional cardiology and future innovation. And it's my pleasure to introduce Dr. AbdulRahman Alqahtani, who will go to or talk about the STEMI program and access to care. Dr. AbdulRahman Alqahtani is a senior, well-known interventional cardiologist in the field. He's the head of the CATH LAB in King Fahd Medical City.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It is my pleasure to be sharing with you our experience of our STEMI programs. Can we have the slides up, please? Okay. So before I start, I'd like to thank the organizing committee for giving us the time to share our experience on this platform. I'd like to thank our colleagues who are moderating the sessions. Before I jump into STEMI care, I'd like to share with you a single experience, a scenario we ran with 2 years ago. I had the pleasure of interacting with this Indian patient. He's 47 years old, who has hypertension. He was a smoker. He had chest pain for 3 hours. He was picked up by our colleagues from the emergency medical services and was brought to us because of this ECG, which shows inferior STEMI. We are using this patient to open the platform to talk about STEMI. What the current recommendation is suggesting is that if a patient has active chest pain, they should be presenting themselves to a hospital or should call the emergency medical services. In our situation here is the Red Crescent or Hilal Ahmar. And if a patient is diagnosed with a STEMI, it will depend where he's diagnosed with a STEMI. If he's diagnosed in a hospital that has a CATH lab, or if he's diagnosed in a hospital that doesn't have a CATH lab. So if he was picked by EMS or he presented to a hospital that does not have a CATH lab, and the ECG was confirmatory that they have an ST elevation MI, the patient should be transferred to a CATH lab-based hospital if the transfer time is less than 2 hours. If it is expected that they will take more than 2 hours, then at that time, the patient should be given thrombolytics to hopefully alleviate their problem. The aim of those patients when we transfer them is that we're trying to get them to get the artery open in less than 90 minutes, even though the transfer time should be less than 2 hours, but we should be aiming to get the artery open in less than 90 minutes. But if we decided that the transfer time is longer and the patient need to be receiving thrombolytics, we should aim to give the thrombolytics within 10 minutes. So if you diagnose somebody with a STEMI, you want to give them thrombolytics, you should start it within 10 minutes. And within 60 to 90 minutes, you need to assess if they are responding or they are not responding. If they're responding fine, then they can be transferred for BCI in 48 hours maximum. But if they failed, then they need to go for rescue BCI, which is an emergency BCI to help them open that artery. Current guidelines also recommend that in the first 12 hours, primary BCI for patients presenting with a STEMI is acceptable and is the best things to be done. And if they cannot receive primary BCI, then they should be considered for thrombolytics. But after 12 hours, from 12 hours to 48 hours, you still, if they're symptomatic, can send them for coronary angiogram and BCI. But if they're asymptomatic, less than 48 hours from the onset of chest pain, then the intervention becomes, maybe acceptable. But after 48 hours, you should not be considering intervention. Why is it important? Why is it important that we take patient quickly and fast to the cath lab, to a hospital that has a cath lab ready, and take them from the field directly to the cath lab rather than, take them to a hospital where there is no cath lab and then transfer them. From 2006, the studies start to come up to show the importance of field transfer to the cath lab in patient with STEMI. What it shows that it actually reduced mortality. People who present to a hospital where there is no active cath lab will likely to have higher mortality compared to people who actually present to a hospital that has an active cath lab. And the reason for that, because time in cardiology is muscle. When patients present with an active heart attack, the time that requires you to open the artery, the longer the time, the worse the outcome. So in order to achieve the best outcome, we always have to strive to get the patient with active ST elevation MI directly to the cath lab in any shape or form, the fastest way, the best way that we can get them. What is the world experience currently when it comes to STEMI? So this data came from the European registry. And what they showed, the European registry, that out of their patients that present with STEMI, in general, in total, 72% will receive PCI, primary PCI, 19% will be thrombolized, and only about less than 10% will not receive any therapy. Saudi Arabia falls in the non-European Society of Cardiology Middle East. That includes Saudi Arabia, Iraq, and Iran. And there are certain centers that was participate in this registry. And what you can see, compared to the average, we are way below, those centers that are participating. Primary PCI is done less than 50% on those patients, and the rate of thrombolytics is extremely high. We know that mortality is worse with patients that present with MI, but if you can revascularize them using BCI, their mortality is less compared if you give them thrombolytics, and even worse if you do nothing. So the best thing if a patient presents with acute heart attack with a STEMI, try to open that artery. If you cannot get them to a cath lab, please thrombolize them. Don't sit and watch and say, they will get better, because their mortality is higher. When it comes to reperfusion rate, those are KPI. You're trying to reperfuge patient with a STEMI in less than 12 hours. The Middle East, they're doing pretty okay. But in timely fashion, like in 90 minutes framework, we're not that great. We're about 40%. So those are, the international data. Those are from Europe. How about in Saudi Arabia? What's our local data? So our local data, we have the first registry that was published in 2019, STAR registry led by Dr. Khalid Habib and his group. What they showed, first, they contacted all the hospitals in Saudi Arabia that has cath lab capability, or even they don't have cath lab capability. And what they found, that out of 370 hospitals, only 50 hospitals first, they participated, okay? And then what they found, that the number of people who present with acute coronary syndrome first tend to be younger. The average age is 55. The average age for STEMI in European countries and North America is about 65 and higher. And also those patients who present, 50% of them were Saudi. The type of STEMI, where the majority were anterior STEMI, so even the worst type of STEMI. So our patients tend to present younger with the worst type of STEMI. And when you look at risk factor for STEMI versus non-STEMI, you look at diabetes, hypertension, smoking, and hypercholesteremia. All those risk factors, the important risk factors that predispose you to have heart attack, they are higher in our population compared to other population. But when they looked into number of patients that present through Red Crescent, they were a very small percentage, only 5.2% of patients, not only for STEMI, even for non-STEMI or for other. So they looked into details into what time frame those patients present. So from the onset of symptoms until a patient may make a contact with medical services, about 2 hours. And if they were contacted with medical services, whether that's in the field or other hospital that doesn't have a proper cath lab, the time is required to transfer those patients, unfortunately, is another 2 hours. So almost 4 hours are wasted before the patient comes to a proper hospital with a cath lab. And once they present there, the numbers are the same compared to any North American or European centers. Our data also, when it comes to getting ECG on time, is less than 50%. And if a patient is supposed to receive thrombolytics less than 30 minutes, again, less than 50% of our patients achieve that. And to achieve opening the artery in the required framework is also small. Not going to go into details, but even people who were thrombolized and they failed thrombolysis, only 38% of that make it to the hospital to get their artery open. So in general, we were not doing great. We actually were doing very, very bad when it comes to proper care for patients with a STEMI in our society. The mortality at 1 year was definitely higher in non-STEMI patients because they present late, but for STEMI, it's about 3.8%, which is still considered to be higher. So at that time, they initiated the first initiative in 2015, which was the Saudi STEMI initiative, and it was a pilot phase. They only did about 160 cases, and it was basically taking patients only in Riyadh present with the STEMI to 2 hospitals, King Fahd Medical City and the University, King Khalid University Hospital. And what you can see from July 2015, the number of STEMI cases that was presenting was significantly higher. But that initiative died quickly within almost 6 months. I'm going to pause for a second to bring you to this psychologist, Philip Zimbardi. He's quite known for a crazy experiment like Stanford prison experiment. But what's important before that, he talked about this experiment, or what he called broken window theory. And what he did, he brought 2 cars and put one in a poor ghetto, poor suburbs, and the other one in an affluent suburb. And he basically left the door open. So the car that was in the poor suburbs was vandalized right away. The one in the affluent suburb, nothing happened to it for 2 days. So what he did, he broke the window. And within the same time, the car was vandalized. And what this signifies that if you have a broken window, a broken thing in your system, and you fail to fix it, and you see it, it will invite others to continue to break other windows in other systems. So somebody has to step up and fix that window. Otherwise, it will invite more problems to come. So that happens to meet one of my passion about STEMI. Red Crescent was grace enough. They were looking forward to start a program. In November 2021, sat with the Red Crescent together. We initiated the first Riyadh STEMI program. And the protocol was simple. If you pick up a patient with a chest pain and you think that patient has STEMI with the ECG, you share it with us. We agree. We activate the cath lab if it's within 120 minutes. If the patient does not have a STEMI or borderline, then he go to ER. So I'm going to take you back to the case of the Indian guy. So this was the first STEMI case in our program in November 2001. So the patient came with active chest pain, inferior STEMI. What we can see here that his LAD has a significant occlusion in the mid segment, but his LCX is fine. And his RCA was completely occluded. And we fixed that right away. And if you look at the time from the time where the emergency medical service arrived until the patient has his artery open is 33 minutes. That is a very, very short time and very good time. So the patient was brought the next day, we fixed the other artery, and he was discharged. And here I'm sharing with you our experience in King Fahd Medical City. So for over the last 18 months, we're starting in November of 2021, we had only 38 patients coming through the Red Crescent, and you could see the number increasing. So in 2022, we had 200 patients coming through the Red Crescent, 116 coming through our ER. So the ratio was reversed completely, and so far it continued to be the same. Most of our patients coming through the Red Crescent. And here's the number. So compared to what Dr. Khalid Al-Habib and his group found in 2015 survey with TrueStar 1, from the time of activation until the emergency medical service arrive now, it's about 20 minutes. And from the arrival until the ECG is done, it's within time frame of 10 minutes. And the average time from first medical contact until we cross with the wire, the artery, is 6 to 8 minutes. So we are within the KPIs of the guidelines. We're actually doing better than most of the country right now if we continue on this time frame. And given all the effort that was done by our colleagues in the cath lab, interventional cardiologists, nurses, technician, and the help of the administration and the support of our leaders in the cluster 2, Alhamdulillah, we were awarded ADA award for the best cath lab this year. And with that, I would like to conclude my presentation. Thank you so much. Now I'm going to ask my colleague, Dr. Abdullah Alhamdan from Red Crescent. He will share with you some more information about the STEMI program. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Hope all of you fine. I'm glad to be here in this forum. Also, it's my pleasure to present our experience in front of all of you. Today, I'm going to speak about our experience with the STEMI project. Hope to be, inshallah, enjoyable lecture. So, because the time, I will start directly. So, the activation of the cath lab in the pre-hospital stage is programmed to facilitate access to the BCI center by diagnosing the patient in the field and transfer him directly to the cath lab by bypassing the emergency department. This initiative came from the big project in the Saudi Red Crescent Authority, which is regionalization of care, and it is a program to improve the patient outcome by directing the patient to right facility with optimal capabilities to deal with such patients. I mean, we are matching now the patient needs with the specialized hospital. So, in case if we have a STEMI patient, we'll shift him directly to the cath lab, and also we'll activate the cath lab pathway. If we have a trauma patient, we'll activate the trauma pathway, and also we'll shift him to trauma center. So the patient journey, it will start once the patient call us complaining of the chest pain through one of our channel, which is 997 or 937 or through 911 or through the As'ifni application or through the Tawakkalna. The dispatcher, they will answer this call, and they will ask the patient 5 questions to just differentiate between typical and atypical presentation. And while the dispatcher asking the patient, he will send appropriate ambulance to the patient. Once the paramedic reach to the patient, they will provide all necessary medical services, including the vital sign and the ECG. Then they will raise it to our consultant in the medical control. And after that, if the STEMI criteria met, he will activate the pathway, and he will alert the receiving hospital. So the outcomes of this project is reducing the patient waiting time, which will save lives. As we know, the time is muscle. Also directing the patient to appropriate care. Also the facilitating access to the medical care. Also reducing the impact of STEMI. As we know, each delay, it will increase the mortality and the morbidity. Also to optimizing use of the emergency department and improving the financial performance by prevent secondary transfer. So this is our number. We reached to 546 patients. Most of them was Saudi, and the 257 was from another nationality. The average age, it was 54. The response time, it was 21 minutes. The mean of the response time is the time between the call and the first medical contact. And from the first medical contact to wire time, it was 75 minutes. And the number of the hospital with us now, 33. And here in this section, you can see that the distribution of the patient according to their gender. So we have 493 male and 53 female. So now I am going to show you our new platform or application.
Over the years, transferring critical cases from the patient site to the hospital has taken a lot of time and effort. The tedious process begins by reviewing patient information received from the e-paramedic via web link. The following step involves finding a specialized hospital for the case from various WhatsApp groups. Finally, the selected medical team receives an alert of the new cases through a pager. However, Sahab has significantly shortened this process via their innovative Maserat system, which aims to quickly direct patients to special care units and save their lives. Through this process, Sahab has achieved seamless integration through the e-paramedic platform that provides a healthcare ticket, enabling the medical team to review the patient data. The healthcare ticket is then sent to a consultant in the Maserat system, and the whole process is further managed in an automated and documented way. By showing and activating the healthcare ticket, the system finds the appropriate hospital for the case and enters the patient's data, thus allowing the hospital to receive patients through the system. In addition, this system provides careful monitoring of all hospitals, healthcare tickets, and doctor shifts. Sahab is here for technology solutions, innovation development, and more importantly, here for the people.
And now I will show you our new app, which name Saja. So as you can see here, we chose this logo because this application is dedicated for 3 pathway, which is STEMI and stroke and trauma. And we named this app Saja because we take the first letter from each word. حرف السين السكتة الدماغية، حرف الجيم الجلطة القلبية، حرف الألف الإصابات التروما. So now you can log in through this application through your mobile number or through the email. You will receive the OTP code to confirm you are the one. So now you can see this is the ticket. It will come to our consultant in the Saudi Red Crescent Authority. As you can see, the color of the ticket is red. That means it is a new ticket. So when you press this ticket, you can see here, this is countdown time or timer. With this application, it will give you 10 minutes to just decide this patient needs activation or no. So you can see here the name of the patient, you can see his age, you can see his gender, you can see the nationality, you can see the patient ID, you can see the mobile number, you can see the ECG, and also if this patient have a previous ECG, you can show it from this option. Also, you can see here the structured history for this patient. Also, you can see the vital sign. Also, you can track the patient. Where is he exactly now? Also, you can try to communicate with the paramedic and the medical control doctor. Also, you can see the medical report for this patient. And also, we put for you the STEMI protocol to just remind you about our pathway. So, if the ECG meets the criteria of the activation, we will press here, activate. Then we will see the available hospital at the meantime and the nearest hospital to the patient. As you can see here, the map view, you can see the patient is here, and this is the nearest to hospital. Also, you can see the nearest hospital by kilometer and also estimated time for arrival. So you will select 3 hospital, for example, and then we'll send the request. This request, it will go directly to 3 hospitals at the same time, and we'll give him 2 minutes to decide whatever, accept or reject the case. And we can see, we can monitor the hospital from this application, like now here, for example, King Faisal, he is reject the case. Prince Sultan Military Hospital, he's reviewing the case. King Fahad is still not opening the case or the ticket. And after 2 minutes, if no one responds, you can send another request, and we will give him also another 1 minute and a half. And as you can see here, the King Fahad accept the case. So we will select the King Fahad. Then we will select send the patient. Then we will confirm. That's it. This is from our side. So from hospital side, he will receive a ticket like that with the time, with the countdown timer, with nationality of the patient and the age and the gender and the ECG and the structured history and the vital sign, and two options, accept or reject. If he press accept, so by default, he will wait maybe for 1 minute to just know which nearest hospital accept the case. Maybe we have 2 or 3 hospitals accept the case, but we will select the nearest hospital for this patient. So he will wait maybe only for 30 seconds or 1 minute. After that, we will confirm the direction of the patient, and he will receive message for that. When he receives the message, by default, also, if he put his staff with him, it will reach to them a message that mean the doctor or the intervention cardiologist, he activates the CATH lab and please come to the hospital. He can know his staff from here. Also, he can know the shift schedule from here. Also, he can change the schedule or send the request through this application. Also, he can put his status busy if he have STEMI in his ER from here. Just change the status to busy. And you can put even how many hours you need to be ready after that. And finally, I'm so sorry, Doctor, take a long time. From here, we can observe the STEMI project, how many hospitals we have, how many tickets we have per day, per month, per years, inshallah, the average age, the gender, also. Also, you can see the hospital with you, who are ready, who are online, who are busy, who is offline. And you can put even your schedule from here. You can manage your shift time from this website. So that's it. Thank you.
Thank you very much. It's have been a great presentation and overview for both of you, Dr. Abdulrahman and Dr. Abdullah. I think it's a great initiative. It really translated to more data, and we have been shown what you present, Abdulrahman, that it's door to balloon time is becoming less and becoming more efficient in dealing with this type of patient that they need acute care. I think the question for all of you is the engagement of all center, and at least in talking about the program in Riyadh. I know nowadays the initiative in King Fahd Medical City, we're planning to make it global in all center. I think we are lucky now by having at least 7 or 6 directors of cardiac center from different health providers. So what is the challenges to involve everybody in this program?
I think Dr. Abdullah might be able to answer that from his point of view.
Insurance, who will pay for this patient? So we try to solve these struggles, and we try to help them. We contact a lot of institutions to find a pathway for this patient doesn't have insurance to ensure for them the care during his stress.
Great. Well, this will open up any comment or question from dear panelists.
So, Dr. Abdullah, just a follow up. We know that MOH basically has approached most of the hospital PCI capable to sign agreements with them. has, to provide acute care. And I guess the cost in private hospital will be handled by MOH. This is my understanding, at least in the Eastern Province, probably most of the region. Is that in partnership with EMS? When they sign these agreement, are you on board with them?
But if the patient condition doesn't allow us to go to the MOH, we'll transfer the patient to nearest hospital, which could be private hospital. The struggle starts from there. Because the private hospital, they want to ensure the payment method, and they try to contact the Shira al-Khidma services, and they have some rules to accept the case. So because that, we are struggling, and we are sticking that.
If I may just, it's an excellent program, and I really congratulate you and King Fahd Medical City for starting the initiative. And I think the data is great from one hospital. But unless this program is really national and involves all the centers in Saudi, I don't think we're going to see an impactful meaning overall. It is, we talked about eligibility as a main concern. We actually just started as part of the program, National Guard Health Center in Jeddah. And one main concern was eligibility. When finally we got that sorted out, but I don't think a lot of places will have that luxury of sorting out eligibility. The other thing, it's still kind of concerning that 2023, we still have hospitals that are not 24/7 primary PCI. If you have a CATH lab and you have a staff, it should be 24/7 PCI in all centers. But I hope that what we see in KFMC translates into all the hospitals and all the sectors as well.
Thank you very much. Any question from the audience? Yeah, Dr. Mohammed. Can you give a mic to Dr. Mohammed?
Thank you so much. I'm going to talk about this from a different perspective, not a clinical perspective, but as an administrative perspective, because I work with Dr. Abdulrahman, Dr. Abdullah very closely. And I remember when we meet the first meeting, it was with the Ministry of Health, and we start discussing the activation for the Crescent. The problem with this program, it needs a lot of dedication and commitment from multiple stakeholders. The primary stakeholders is interventional cardiologist, but there is a lot of logistics actually going under the scene, which is run by administration to make sure this program is vital. And this comes because of CCU bed availability, technicians over time, a lot of things, happening, I think making this program successful and maintaining, you really need a very high support from administration, from very top administration, from the institution, to make sure that this program can run and can go smoothly. Because I don't remember we ever turn a case. We never turn a case. Even if our CCU is full, we still manage to accept all the cases. Sometimes we run 2 codes at the same time. We created a backup team, running codes, sometimes borrowing beds from ICU, from everywhere, just to make sure that we never turn a patient down because of how this is vital. And actually, the things that Dr. Abdulrahman present, which I present, the impact of this program. We show decrease in mortality, we show improving the heart function, decrease hospital stay of heart failure, and decrease recurrent hospitalization on those patients who actually tackled with a PCI. So the impact is there. But I agree with Dr. Rasha. This program should be like really a national program. The other thing is about the eligibility. I think this is a life-saving procedure. I don't think we should discuss eligibility. This is what we did in King Fahd Medical City, except even patient with no ID. Because if the patient comes with a STEMI, he will lose his life. So I think this has to be taken to at a national level, because this has to be halati, like 937. Any patient comes with a STEMI should be life-saving. So forget about eligibility. You should have an access to the medical care right away, and then you deal with eligibility later on. For the private hospitals and the payment, this things it's back and forth. But this also again goes as a life-saving, And all this has to be discussed, because if we want to take this to the next level, we really need to put everything with high administration involvement, and from the Ministry of Health, from the Red Crescent, and from the private hospital sectors, and also مجلس الضمان الصحي, because they are the one who is actually putting policies and procedure. This will make this program much more effective. Thank you.
More than 10 patients was rejected from the Saudi Red Crescent Authority. I feel so bad about them. And we raise that to the MOH, also we raise that to the الصحة القابضة. Also, we try to follow up the result of this complaint from us. Yeah, it's a life saving, as you mentioned. So you don't have a right to reject the case while you are, or you can do something for him, and you can later on talk about the payment.
Can I just say a follow-up thing? You know, Dr. Khalid Iskander with us. Actually, you know, at Babtain Eastern Cluster, we've actually never rejected any patient. They just, actually, there's a policy at MOH. They will transfer the patient, sometimes even if we refuse or busy, okay, as life-saving. So there is a policy that exists in place. And I think it comes down to implementation of these policy across different sectors. It's my understanding that should be basically adopted by every single center in the region. I guess the cost, etc., comes later after, you know, saving those lives.
Can I? On those patients after their discharge, some hospitals will close their files. So do we have any data on their follow-ups? Who's giving them medication, especially for non-Saudis?
Divert the.
No, I meant if they go for primary PCI,
No,
and then
they
after
did not
that,
go for the primary PCI.
for those who go for primary PCI, what happens after their file closed at that certain
We
hospital?
don't have the outcome, unfortunately. Because that we built this program to let us about our outcomes, also the outcomes from the hospital. So we ask him every week to give us the outcome, but you know, it's manually. So
I'll just give feedback on that point. So any patient who present who's not eligible, non-Saudi, for example, they receive the proper care until they are stable to be discharged. Once they discharge, they get 1 year supply of medication. So every 3 months, they get a refill. Yes, they are not eligible to come as an outpatient, but at least they have 1 year of coverage of the medication. We give the recommendation to go and seek a cardiologist in the community private hospital so they can follow up that. But in terms of their medical coverage, they're covered from our hospital for 1 year. And after that, they have to transition. Most of the patients, they come with an insurance. They're not the best insurance, type C, but it's enough for them to see a cardiologist in the private hospital and follow from there. So they do have a plan. In terms of outcomes, I think the program should include assessing outcomes, and part of the outcome is to have a dedicated methods of reaching those patients by at least phone calls to make sure at least what is our mortality at 30 days. We know our mortality at 30 days because we reach those patients, but at 1 year, we don't have that information. And I think that program should have under its umbrella part of the program dedicated to actually assess the outcome of those patients at 1 year. Saudi patients, we have them, but remember, 50% of our patients are non-Saudi that present through the STEMI program, 50%. So we are losing half of the stacks of those patients if we don't have a proper system to check the outcomes and educate them appropriately.
I think the most important thing here is to maintain the program. And I think the demand going to increase more and more, and the patient requirement will be more, number of patients will be more, as if you are increase the awareness. And the hospital involved has a limited resources, and they cannot cope in the near future. And my advice is just to try to push for more support, as Dr. Mohammed said, and try to expand the program and include multiple centers. We have the same experience with the King Khalid University Hospital in 2004 15, I guess, with the King Fahd Medical City. At that time, we started a program with a Stent for Life, and STEMI cases jump from 8 per month to 100 per month. And all of a sudden, a lot of demand, and interventional cardiologists are almost in the cath lab. They cannot leave their work. So yes, it's a great initiative, but I think the most challenging now is to maintain it, and by involving more center to have more services will be the key.
Currently in Riyadh, we have two governmental centers. Us and Ashmisi are operating together. There are a couple of private centers, Al Habib, all of them joined, and I think now Riaya is joining, and Saudi Al Almani is joining. Those will take some of the load off. We at the beginning we had to create a second team because we had simultaneous, sometimes 2 STEMIs, sometimes 3 STEMIs, and we have never turned a case down because the dedication from our side was we have to ensure that every patient should receive the proper care. And sometimes you need to prioritize. Some patients are stable, you could delay them for about 30 minutes. Some other ones you have to take them right away. Thank you.
No, the involvement of EMS is a cornerstone in STEMI care. Okay, because most of the barriers basically could be easily overcome by involvement of EMS and having a very effective EMS system. Question to Dr. Abdullah, what have you done this time around to increase utilization of EMS by patients compared to, previous data from space registry?
So we start internally to train our paramedic how can they do the ECG for each patient complaining of chest pain. After that, we face a lot of struggles because we don't have enough ECG machine in our authority. You can imagine that we have only 140 machine, and we have more than 600 ambulance. So alhamdulillah, we try to raise that to the higher level, and we got alhamdulillah 50 million to inshallah bring a lot of machine. Then, inshallah, I think we have a shortage in the awareness and in the media exactly. So we have awareness campaign, inshallah, next month, and after that, I think the number it will be increased, and also our community will know about the services, what services we are provide. So hopefully, inshallah, it will be helpful.
Question.
Okay. I have one comment and question. The comment I would like to congratulate actually this program. That's absolutely a great program. I think substantially increase the survival for sure. Okay, I am from Medina. I can in Medina definitely it increased substantially the savings of life, as well as the program is exponentially increased the involvement of the people. There were some challenges initially was knowledge base, especially the EMS personnel. What we did, we actually call all the EMS personnel to our hospital, and we train them the basic ECG, so they can determine the STEMI at least. And then we keeping this program on with the Red Crescent guys there. Okay, that's helped a lot actually to understand. But what happened after that, when we start the program, our number of STEMI was high to begin with, but it increased even way much more. So now our bed, emergency room bed, all these logistics need to be increased. This is one of the challenge, logistics. And then other thing is that what is the problem still? There are a lack of manpower and lack of coordination is still there. The time of door to balloon has substantially reduced. Okay, that is a big improvement. Our particular challenge is the geographical area, quite diverse. So just from the Medina city is okay. From the outside the city is a little bit still challenging. So maybe that can be looked into. And I absolutely agree with Dr. Fawaz Mothari. The main thing is to sustain the program, to maintain the program, and constitution, continuously, surveillance to improve the quality and efficiency by continuous education. So we are keeping every 6 monthly refresher course of the basic symptoms and signs of STEMI patient, as well as the ECG and the vital signs. And we are able to reduce the cardiogenic shock from MI. There are certain help, but I think I would say still we have a long way to go. So actually, this is we all have to focus on this program. That's going to be substantially changing our healthcare pattern a lot. Thank you.
Thank you very much. Thank you for your presentation, Dr. Abdulrahman, Dr. Abdullah, and congratulations for this success and this collaboration. And I think with this, we'll stop for lunch and prayer time. Then we'll come back sharp at 1 o'clock to resume our program because we do have a live transmission ahead of us. Thank you.